Yeah, and I apologize for all these little weird little. Yeah, I hate it when a word cuts off in the middle of the thing, and I apologize for that, but we're gonna get through it, okay? The main thing that's important to know is that 50% of the population has an incomplete, circle of Willis, okay? Or an ideal circle of Willis, so they may have a hypoplastic vessel or whatever that doesn't flow very well, but half of people don't have a complete circle of Willis or a completely functioning circle of Willis, right? And that circle of Willis protects us because it gives us an alternate way of blood flow to the brain if something is blocked. But in terms of population studies, we have some some vessels that are really more commonly either incompletely developed or not there at all. Okay? What page are we on in your book?
This is 41.
41.
Yeah.
Okay, perfect. Okay. So you may have something on this. If you take the test, you may have some questions about this. The A1 branch on the ACA, and I wish I had a pointer. I don't have a pointer. The A1 branch. Okay, let me do it this way. You have carotids. I'm sorry, y'all. I have to do it this way. You have carotids that come that obviously come off the arch. And so you have your carotids. Is that a pointer?
You get to turn it on. There's like a switch on the side. It might operate the PowerPoint too.
Oh, cool. Okay, where's my little? All right, how do I do the pointer? There it is. Oh, hallelujah. Okay. Now I feel like I can do something here. Okay. Right. So coming off the carotid, so we're coming up the neck, and you have the common carotid, and it bifurcates into the external and the internal carotid. Obviously, the internal carotid is the one that comes up through the head. And the external carotid has a bunch of branches on it that feed the face and that kind of stuff. One time I had a patient who unfortunately had a bad head injury, and both of them were blocked, both dissected, highly unusual. And he was brain dead, but he didn't look brain dead because the ECAs had blood flow and he had good color and all the things, but he literally was brain dead. It was really sad. And that was hard on the family because they couldn't understand he looked so good, but wasn't there. It was a hard one. Okay, so you have the internal carotid arteries coming up. It's gonna bifurcate right here, and it's gonna take a steep, sort of a steep curve over here to the anterior cerebral artery. You have two of these. Okay, it's gonna take a steep little curve over here. But it goes right here. The ACAs are right here above the forehead, bilaterally. It's just right back here, okay? The MCAs, less of a curve, less of a curve here, and it just keeps going out this way, okay? So those are your middle cerebral arteries on both sides. Now your ACA has a communicating artery right there is the ACOM-A, the anterior communicating artery. You only have one of those. Okay, and the branches are numbered. So as it comes off of the internal carotid artery, this branch of the ACA is A1, and then it shoots up here. This branch is A2. So this is the A1 here on this side, and then A2 is the second branch. Okay, MCAs do the same thing. You have your ICA, once this branch comes off the ACA, now you're into the middle cerebral artery, okay? That first branch is gonna be your M1. You've heard of an M1 occlusion? That's a very proximal occlusion on that MCA coming right off the ICA. Sometimes you'll have a tandem occlusion, where the ICA and the MCA have a clot in them, and nothing's getting past that, okay? Remember we talked about these little perforators, these little small vessels coming off? MCA has those, they have the lenticulostriate perforators. That's what the basal ganglia, that's the blood supply of the basal ganglia of this MCA. They're teeny tiny little vessels. You never see them on imaging. The ACOM-A has some too. You'll have aneurysms here too, okay? Off of these little bifurcations. Bifurcations are really good places for aneurysms because the blood flow just slams up against that wall, okay? All right, so ACA is here, across the forehead on both sides. Forehead, both sides back. MCA is here, all across the side of the head in branches. A1 branches into two branches, an inferior superior, M2. Okay, so you have M1, M2, M3, M4, right? Do y'all do MEVOs here?
EVOs.
Okay. Okay. So those MEVOs didn't exist 10 years ago. I'm just gonna tell you right now, they just didn't exist. We didn't have the catheters. We had chromic catheters prior to 2015. So the catheters are getting more so that they're getting out to M3s, and getting out to those small vessels, which are branches off of branches off of branches, right? Okay? All right. So all of this is ICA. It may surprise you to know that your PCOM, your posterior communicating artery that communicates on both sides down here to these posterior cerebral arteries to complete that circle, it may surprise you to know that these actually in fetal development come off of this, come off the ICA, okay, in fetal development, and they reach back, which is why they're called posterior communicating arteries, because they're reaching back to communicate to the posterior circulation, right? We looked at those perforators before on another side, those thalamogeniculate perforators, the thalamus, okay?
Say that again, sorry.
Huh?
What did you just say? I'm sorry.
About the posterior communicators?
Yes.
The posterior, and fetal development, the posterior communicating arteries originate from the ICA, and they reach back here to connect. It's not the other way around. They're not back here and then reach forward. They're here and they reach back, okay? And the reason why that's important is because sometimes we either have a hypoplastic, in other words, it's really small, diminutive PCOM, or we don't have one at all. And you may see on the reports fetal PCA. That's what that is, okay? All right, that means the PCA really has to carry a lot more of that load. But the PCOMs can be hypoplastic because maybe you don't need all that. Maybe you have good blood flow here, and you have good blood flow here, and you don't need a whole lot of communication here. And so it's sort of flow dependent, really. If you don't need it, they're really sort of just passive, really. Okay. So coming down from, so this is all, so when we talk about anterior circulation strokes, I'm talking about ICA, MCA, ACA on both sides. That's typically anterior circulation strokes, right? We talk about anterior and posterior circulation strokes. That's anterior of these vessels here, okay? It's on the front. Coming from the back, you have your vertebral arteries, and I hope we have another picture showing you where they come off the aortic arch. But for right now, you have your vertebral arteries, and this is one of the few arteries in the brain that converge instead of diverge. They converge to form this basilar artery right here, okay? And many times you will see one of these vertebral arteries being dominant, and you'll see that on the CTA report, dominance of the left vert or something like that. So you'll see that, and that can be quite common. But you have your aicas, you have your posterior inferior cerebellar arteries, you have your aicas, which is your anterior inferior cerebellar arteries. And sometimes you'll have aneurysms here too, like a pica aneurysm or aica aneurysm. Okay. These are your pontine perforators that give the vascular supply to the pons. Basilar artery right here. The very top of that is your superior cerebellar artery, and then your posterior cerebral artery. This little segment right here, before it bifurcates, before you get the PCOM-A sort of attachment, is P1, and then you have P2 over here. So P1, P2, okay? So you can have poorly or incompletely developed segments at the A1 branch, which is here. It can be completely non-existent. And it doesn't matter as long as you have blood flow coming from that contralateral vessel. Does that make sense? So you can be without it. And I will tell you, when I took my AMVP on the test and they asked me questions about, because it was heavy on imaging. So it was like, how would you get this kind of stroke? You know what I did? I sat down and I drew this out. And I put an X across a vessel. And I said, what would happen if I didn't have that blood flow? That's exactly how I drew that, because it was hard to wrap your brain. The P1 branch of the PCA, so this could be missing, and they get blood flow from the PCOM down to the PCA because this P1 is missing, or the posterior communicating. Okay. So those are probably that's probably something that you want to know. All right, got it? Okay. Well, it's not going to work because I've got my stuff right here. All right. So this is why we're going to break at noon no matter what, because I don't want your eyes to glaze over. Again, you have these large arteries, right? This is MCA here, and you have these small artery perforations, right? These are your large vessel occlusions. These are your lacunar strokes. These very small vessels, those perforators, are your lacunar strokes. Okay. Just want to show you that in a different way. Okay, on that. Okay. All right, so let's look at territory for just a moment. Your brain is obviously in two halves. And for each half right here, ACA territory. On the most medial side of both halves. Then you have your MCA territory. Then you're gonna have your PCA territory in the back, okay? We're not gonna get into antichoroidal or any of that kind of stuff, okay? And so you can, so these are the territories, so that when you look at CT and you have abnormality in a territory, then you kind of know where that territory is. So ACA across the top and back, MCA on the sides, on both sides, and PCA in the back, okay? This is the vascular territory. All right, so let's talk about the cerebrum for just a moment, okay? The cerebrum is everything above the cerebellum, okay? That's the cerebrum. And you have your frontal lobe, your parietal lobe, your temporal lobe, and your occipital lobe. And each one of these lobes does something different, which is the reason why when you have a brain tumor, when you have a hemorrhage, when you have an ischemic stroke, you're gonna see something different in the presentation of that patient because it controls something different. This is the foundation of localization of stroke, okay? So you have two hemispheres separated by the longitudinal fissure, and it's joined by the corpus callosum. The corpus callosum is the translation cerebrum right between the left, right? So if we have funky things going on in the corpus callosum, people get the right and lefts mixed up. Okay, this comprises 80% of the brain's weight, and that outer layer. Let me see if I got. Do I have a? Yep, I'm going to go back to this picture here. This very outer layer here that has the convolutions right there, that is the cortex. Very outer layer right here. Okay, that is the cortex. So when we talk about cortical stuff, that is the cortex. Everything else is subcortical, and that's going to come into play in just a moment. Okay. 2/3 of that cortex is buried in all of this, right? Our brains, if we had to line our brains out, I'm sure it would be quite some distance long. This contains the cell bodies of the neurons, and the thin outer layer is gray matter. So we're going to talk about gray-white interface in just a moment. The outer layer doesn't have to be fast. But below that has to be fast because we have to translate impulses. From what I'm moving my arm. I want to move my arm. Well, when I want to do that, the outer layer doesn't have to be the fast part. But the axons, the neuronal axons that translate what I want to do to my arm have to be fast. So they have to be like myelinated and all of that kind of stuff. And if you remember way back when you talked about, the myelin sheath and how it transmits, and basically is a super highway for impulses to get through. That's what this is underneath that cortex. So the outer layer of gray matter is the cortex, but up underneath it is the fast signals that go from the cortex to what I want to do, and that is the corticospinal tract. So it goes from the cortex down through the spine into my arm, and I want to click this button. Okay, the cortex doesn't have to be fast. Everything below it that's transmitting that message has to be fast. So it's white matter. Okay, we're digging deep, guys. Digging deep. Here's the main function of the cerebrum. Intellect, our ability to learn, right? Our ability to be educated. Our memories are stored here as well in the cerebrum. All of our language is stored. Our ability to speak, our ability to understand language is all housed in the cerebrum. And linking things. I know this is a phone, okay? But if I had some big stroke where I could see it, but I couldn't make the association with something that I know, I wouldn't know that this was a phone. So our linking what we see, what we feel, what we, smell, touch, all those things have to be linked to something we know. All that happens in the cerebrum. Very complex. And functional MRI has shown us that more than probably anything else, is what happens when people speak. My daughter, she lived in Princeton, New Jersey. She's getting a degree as an opera singer. And she actually, she did the psych students at Princeton, where they were doing functional MRIs, and I told her, I said, you can participate, but no meds. There's no drugs you can do and all that. And if things get a little sketchy, you can always opt out. This is voluntary. So she did a lot of functional MRIs, like reading and speaking and that kind of stuff. And it's a real complex interaction. All of our motor, and we're gonna see a motor strip in just a minute, all of our motor is housed in the cerebrum. Our sensory, our interpretation of our environment is housed there as well. Okay? Those are the main functions. Don't get messed up with this. Don't worry about this for right now, okay? Don't worry about all that. But in the early 1900s, the brain cytoarchitecture was developed by Corpini and Brodmann. And so we refer to these things as Brodmann's areas because of that. It offers a label, like this is motor strip, this is sensory strip. All of these things have to do with our ability, personality, and things like that. So each of these areas refers to something specific. In neurosurgery, we used to do epilepsy surgery. So we used to do temporal lobectomies, hippocampectomies, and all that kind of stuff. Well, guess what I had to know before I did all that? I needed to know where their speech center was. I mean, if right-handed people, your speech center is usually on the left. And in left-handed people, your speech center is usually on the left. Well, I had, a left-handed person, and I needed to know where the speech center was before I took out the temporal lobe. And so, a system like this helped us, certainly helped them early on identify awake surgeries, where you're doing surgeries where you're testing them and making sure that you're not knocking out something that's important. All of these things are foundational to that, and then we built on that. Probably in the last 100 years, the research on a functional MRI, this particular 1909 study has probably been cited probably over 100 times in the last, and we wouldn't think that would be relevant now, but it's really kind of interesting that in 1909 they could map all this stuff out and be pretty accurate with it. So it's pretty neat. Okay, let's talk about frontal lobe, right here. If you deal with trauma at all in your neuro ICU patients, and if they have frontal contusions, especially in a young male, it's a real challenge. They are impulsive. They don't want it. They're agitated all the time. All of those things, and so the frontal lobe has everything to do with our voluntary motor function through this motor strip, and we'll talk about that in just a minute. Language expression, but also higher intellectual function in terms of inhibition, right? So our frontal lobe is really important for those main things, not in isolation. Okay. Let's talk a little bit more in depth about this frontal lobe. Let's talk about Brodmann 4 right here. It is known by several different names. It is known by the precentral gyrus, because there's a big gyrus, which is all that is a big sinkhole. It's a big crevice between the frontal and the parietal lobe. Is right between this 4 and 3. That big little crevice right there is the central sulcus. And so this is the precentral gyrus. The gyrus is the hump, right, of the frontal lobe. This is where all of our motor comes in, on both sides, right and left. Okay? The most medial aspect of that up here, up at the top of this motor strip, like right here, is ACA. Okay, that's it, because ACA goes all across here. The rest of this side of this motor strip is MCA driven. That's why you have the facial droop. That's why you have the arm weakness. And if do y'all remember the motor homunculus? No, nobody ever remembers the motor homunculus, because you know when we were in nursing school, we weren't going to neuro. We were all going to do cardiac. The motor homunculus is this, and I don't know if you can see this, and I want to point this out. And if I'm getting in the way, let me know. Okay, the motor homunculus is this. So this is, I'm looking at you, and I have a slice of my brain right through here, okay? The motor homunculus is this. In between the two halves, because you have a half over here, right? You have a right and a left. And this is one half of that. In between are the toes, and the ankle, and the knee, and the hip. So the legs are right here. So if you have a tandem occlusion of your ICA with your MCA, it also gets the ACA. So what is your presentation in that patient? They have arm and leg weakness, don't they? So your leg, if they have a brain tumor sitting right out here, they're gonna have leg weakness. And that motor strip, if it's in that motor strip, okay? And it's just in that one strip, so up here, in between the halves of the right and left half, are your toes and your ankle and your knee and your hip and all that stuff. And each of these things, there's various ways to look at this. But your trunk is here too. Now, as you get toward the lateral side, you're getting into MCA territory. Your ACA is coming up here. Your MCA is coming out here with all the branches and all that. So if you have an MCA occlusion, is this, y'all, I hope y'all are getting this. If you have an MCA occlusion, guess what it affects? Your hand, your fingers, your, let's see, how about your ability to smile, your face, your lips, your jaw? How about your swallowing? Does that make sense? On this motor strip right here, up here you've got your leg, up here you've got your hand, your arm, your face, your swallow, the neck muscles, the swallow. That's what makes this territory MCA. That's why you get those symptoms when you have an MCA occlusion. If you have a more distal MCA occlusion that preserves the ACA, you're not going to have any leg weakness. You're just going to have arm weakness. Okay?
So when we're identifying like by lateral aspects, we're saying the lateral aspects of this sliver here, and then the medial is going to be wheezing. Okay.
Yeah, the medial part of this little Brodmann area right here, the medial part of this motor strip has to do with your lower extremity. Okay? The lateral part has to do with your arm. That's the reason why M1 occlusions typically present with hemiparesis on arm and leg, because it gets the ACA in that occlusion. If it gets the ICA and the M1, it gets the ACA sometimes. And not all the time, but sometimes it does. Okay? But if you get more distal, you're going to have some of these other symptoms. Okay? So, and generally that motor strip, that's what that's indicating. All right. So the medial aspects are ACA territory, lateral aspects are MCA territory. And so this is what you're trying to look, this is the reason why when somebody comes in, like I had a young person come in. I had a young person who came in a lot. And they would always have arm weakness, but face weakness was never part of it. And I was like, you're not having a stroke. If you have complete arm plegia, you should have face involvement too, because of all of this being together. Does that make sense? Okay?
And so, again, like that, for MCA to ACA, because the MCA is supplying the ACA, you're not going to see, like, what you're saying is you're not gonna see one deficit without the other in that case. Like, you're not gonna see an MCA deficit without an ACA deficit.
And if you have a big occlusion in the ICA,
Okay.
and that gets the MCA, and then you have, what if you don't have now, is that 100%? Not always, because you have that ACOM that's coming over and giving you some additional blood supply. So the leg may not be as pronounced as the arm because of that.
Okay.
Does that make sense?
Kind of.
Listen, let me tell you, this takes a dark room moment. Nurses are not taught this, and I think it's important. I think we should know it if we're gonna take care of stroke. But anyway, okay. So yes, so the lateral aspects are all MCA territory, and that's the reason why you see those symptoms you do with the arm and the face and all of that. And now you can see the limitation in some of the stroke scales, because they were focused on MCA. Right, that's the reason why we added the B, because nobody cared about posterior strokes. They didn't recognize that eyes, that vision, and balance was part of a posterior stroke syndrome, right? We ignored all that stuff. We were just looking at fast. And so, but this is what we were looking at when we were looking at fast, is right here in this MCA. Okay? I know it's gonna take a minute, I agree, it's gonna take a minute. Okay. So corresponding assessments, okay. Now you can have, when I'm talking to patients, typically when I'm talking to them, I can see a facial droop, but if I can't see a facial droop, I'm gonna ask them to smile, okay? MCA distribution normally affects the lower face, and that is a central seventh loss, it's cranial nerve seventh loss. It commonly spares the upper face, okay? Now, I'm not gonna go, because I think if I go into that right now, I think y'all will boot me out of this room. I'm not, but that's one of the differentiators between that and Bell's palsy. So I'll see Bell's palsy patient, and typically they can move neither lower nor upper face, okay? So just so you know, they can't move any of these, and we always have to look at pontine stroke, because pontine stroke can also get upper and lower face, but typically they have other stuff. Bell's palsy has nothing else other than face, upper and lower, but typically when you have these cranial nerve things, then you're gonna have some other stuff, okay? A normal face with a weak extremity likely suggests a stroke mimic. Just like that patient that would come in, okay? So if you have a normal face with a weak extremity, that's suggestive of a stroke mimic. Now you still have to, I still have to go through the steps. And how do we grade these things? I think you should remember this part. How do we grade them? 0 out of 5 is no movement. Not even a flicker. 3 out of 5 is I can overcome gravity. I can hold it there, but I can do it. Okay, 5 out of 5 is I'm normal. Totally normal. 4 out of 5, so if you look at it like that, then the others are in between, right? 1 out of 5 is a flicker. I'm attempting, but I can't do much. 2 out of 5 is I can't even overcome gravity, but I can do a little bit more. Maybe I can move it side to side or something like that, but I can't overcome gravity by myself. 4 out of 5, they can overcome some resistance, okay? It's helpful to put them, because when you say weakness, I don't know what you're talking about. But when you grade it, I know what you're talking about. And to complicate it, I'll put 4+ out of 5. But anyway, but I'm just, but when we say weakness, I have no idea. And much of our documentation is weakness. it's not in muscle grading. But this is a lot more objective and can communicate a lot better. Okay? Is this in your book? Is this muscle grading in your book? Is it? Okay, very good. Okay. Then I'll be quiet about it. Okay. All right. Area 44 right here in the little circle, right there. That is regarded as your broca's territory. It's most commonly in the left, even if you're left-handed. And this also has to do with written and spoken language, okay? This is where people have difficulty, either they're aphasic, they can't say anything, or they have word-finding issues, okay? It also may be accompanied by this Brodmann's 4, Brodmann's 4. Because remember the muscles and that govern the tongue and all that kind of stuff are down here. So you can still have word finding issues with dysarthria, slurry speech. But again, MCA territory. Because it's on the side of the head. Okay? All right.
Oh, so that used to be Broca's aphasia
Yes, yes.
back before.
Back in the day.
Back in the
Yeah,
day.
Back in the day.
Okay.
I know they keep, I have a neurosurgeon who talks about fluid dysphagia, and I was like, I don't know what you're talking about. That's how I was trained, and some people you just can't change, so. Yeah. So it's Broca's, and Broca's is expressive, remember, yeah. The frontal eye fields, okay. So Brodmann's 8 right here. Don't worry about any of these others, Brodmann's 8 right here. And I'm not so much worried, but it's frontal lobe, right? And it's in front of the motor strip. This is why interruption in this, so saccadic eye movements have to do with this. I have a smooth flow from right to left. I'm not cogging it. I'm able to get over there and it's a smooth cadence from right to left. That's a saccadic eye flow, okay? Some people call it saccadic. I call it saccadic because I'm from Arkansas. Okay. It allows the eyes to move together. So you don't have one eye over here and one eye over here. It allows them to move together very smoothly. If they don't move together very smoothly, you get what? You get double vision because your eyes aren't working together, okay? When you have interruption of this, and this is also somewhat lateral, it causes that eye deviation toward the affected MCA territory. So when you see a patient like this that comes into your ER like this, and they have this side flaccid, what are you gonna think?
Left
Yeah,
MCA.
I have a left MCA, right? And the reason for that is the disruption in this area right here. Okay?
Oh, so the conjugation, it deviates toward where?
Toward the ischemic stroke. Mm-hmm.
Towards this, oh, interesting.
And if
Wait,
you
can you say
correlate
that again?
No, then you have to correlate it with something.
Right.
Because what if you have the eyes here, and then you have weakness over here? That doesn't correlate.
Mm.
That doesn't correlate at all with what you know about right and left control
Right.
of the brain, right? So when it correlates, that's wrong way eyes. And maybe you gotta look at seizure. But if it's your weakness over here, which is what you would expect if you had a stroke over here and you're looking at it,
Yeah,
because now your eyes can't move over here.
so
because
your
this
eyes
side
are
is
looking at your
disrupted.
stroke.
That's right.
Nice
This is
mean,
why
not
that
nice,
is
but
the way it is.
connection.
Yes. Now, let me tell you what, when stuff concerns the brainstem, all bets are off. I'm just telling you, they do some funky, wonky things. You can have some lateral deviation, you can have ptosis and pupillary dilation, sort of like in a Horner's with a cranial 3. So if you have, like when I had that patient with 1.5 syndrome, where one eye was going just fine, the other eye stopped and couldn't go over medially. I was like, that's not a Brodmann 8. I have a problem in the brainstem. Because that's a cranial nerve, okay? So again, upward migration, vertical, double vision that worsens when you look down. This is very unusual, by the way, to have an isolated cranial, fourth cranial nerve, sort of deviation. A midline deviation with limited, all right. Before we get out of here, do y'all have the picture of the cranial nerves? Like the picture with the numbers? Have you ever done that before?
Oh, like the face
Uh-huh.
thing?
Where you do like the twos and where the eyes are and the ones where the nose are?
Yeah.
It's not in your book, I can tell you right now, it's not in your book.
No,
Yeah, there's a chart.
we use,
No, we're gonna draw a picture, that's
Yeah.
gonna make it a lot more, because really and truly, what we should do is give you a visual for that, because
Yeah.
if you look at that chart, I hate that chart, I mean, I don't hate the chart's a good chart. It's just not helpful to you when you want to know, hey, what does the sixth cranial nerve do, right?
mhm.
And so it's not helpful to you to do that. The sixth cranial nerve allows you, hang on a minute. What's happening? My computer ran dead. One moment. One moment, this may be a sign,
Oh
y'all.
my God. I bring
This
that
may be
picture
a
up so many
sign.
times to like
This may be
new
a
grads and
sign.
stuff like that.
We used to have it hanging in our conference room.
Yeah.
This may be a sign, okay. Let me see what we're gonna do here. I'm sorry to get over on all of our stuff over here. I hope my computer didn't just die. Okay, we're gonna give it a few minutes. Okay, hey, turn to a blank page. Anywhere, in the back of the book, on the back of
I'm
something.
sure we have one.
Sure you have an incomplete page or something like that.
There's a lot of space on 50 as the
Perfect.
brainstem.
Yeah, perfect, yeah, do it there, that's where it belongs anyway. Okay, okay. So the one is going to, so cranial nerve one is what?
Nose. Yeah, olfactory.
Olfactory, right, smell. So make a one, like where your nose, so we're gonna draw a face, so put in a one where you think, when we complete that, your nose should be on that face. Do I have a piece of paper? I think I have a piece of paper. Okay.
They don't mind if you draw on the walls here.
Oh. You're gonna get me kicked out, I don't even want
No,
to.
you'll just get curved.
You're gonna get me
He's
in
expendable.
trouble.
I wouldn't say that. He's not that expendable, so he won't get in that way.